Hello everyone, and thank you for watching this video. My name is Karl Buche. I'm a physical therapist and instructor for Great Lakes Seminars. I teach the Understanding Pain course, and we have a question that was sent in about pain that I would like to answer. The gist of the question was, how do I efficiently provide meaningful pain neuroscience education to a patient when time is limited? And that's a really challenging thing for a lot of us because we have so much information about what's causing their pain, and we need to know what information is important to give on the first day, what's most important to wait for future visits, because if we give too much information on the first day, we tend to overload the patient, and sometimes they don't hear anything we say because it's too much information. So what's the most important thing we can relate to the patient to get them on board right from day one? So to answer this question, I want to give a small overview about pain, and then we'll look at a little bit of research based on what is important for the patient to know before they go into their exercise. So when we have in our environment and our tissues giving information, which is only information, through our peripheral nervous system into our spinal cord and then going up to the brain, it's up to the brain to decide what that information actually means. Is it a threat to us or is it not a threat? Because if it's not a threat, the brain doesn't care about it. It's not going to be painful. You're not even going to notice it. But if the brain is threatened by that information, then there's going to be some type of output, which could be pain, could be an altered behavior. Altered behavior just means a compensation, or altered physiology, which could be a stress chemical response, an opioid response, an inflammatory immune response. Something's going to change about the physiology. And this is what the structures in the brain look like that are trying to determine, is it a threat or is it not a threat? We call that our pain neuromatrix. Everybody's pain neuromatrix is different, but all of us have these same 9 structures involved with it. And if you realize that not only are these structures involved with the pain response, but they have other responsibilities as well, which becomes important when someone is dealing with pain for a long period of time. All of our chronic pain patients may have trouble with things like concentration, focus, problem solving, memory. So don't be surprised when their brain is so focused on determining that pain response that they forget their home exercises, they forget their appointments. It just makes it a lot harder for them to stay focused on the task at hand. So when a person is perceiving a threat, when they're having pain, there's differences in what their brain looks like if we can take a scan from it versus somebody whose brain is not perceiving a threat. So if we look at this picture here on the left-hand side, this is a person with back pain, and every time she went into spinal extension, her back pain would flare up. And when they took a picture of her brain during that time, this is what we saw. They saw that this area in the middle here, it's called your periaqueductal gray matter. That area fires anytime the brain is perceiving a threat because it's the start of a descending modulation system. So we know that her brain is perceiving a threat from that. And then back the middle picture here, the back part of the brain, that's where her cerebellum is. And the question is, why would her cerebellum be active during a spinal motion like that? And on the bottom picture, this is her motor cortex, which is really not firing. So why would her cerebellum be taking over from her motor cortex to do the movement? Where our cerebellum is going to be active anytime the body's perceiving a threat because it's trying to make adjustments to our movements to keep us safe. So we know that the person on the left-hand side here, she is definitely perceiving a threat. When they took her out of the machine, gave her pain education, things that like we're going to talk about today, then they, after giving her pain education for 30 minutes, put her back into the machine, had her do the same spinal motion, and they see a completely different response. So we see up on the top here, the periaqueductal gray matter is very silent. Her cerebellum is also silent, and her motor cortex is firing the way that it's supposed to. This is the goal of giving someone pain neuroscience education. We're trying to get their brain to change its firing pattern to perceive less threat, which hopefully will lead to less pain, but also to allow the motor cortex to fire the way it's supposed to so we can retrain the person's brain, their motor patterns the way that we want to. Because the person on the left-hand side, if you have a patient that you're treating who does not have a good understanding of pain and their brain looks like this when they're moving, you're really not retraining the brain like you think you are. So can exercises be painful? The research here by Smith and colleagues, they found that exercises into pain offered a small but significant benefit over pain-free exercises for pain, meaning that we can get people better faster if we work into some pain, but they have to have a good understanding of pain, or else, which I'll show you on the next slide, it doesn't work the same way. So the participants in this study had a good understanding of pain, and they got better faster in the short term. When we get to the medium and long term, they said there was no difference, but it matters to patients to get better faster, and it matters to our clinics as well, that we can get people in, get them better, get them out to make room for more people to come in. Other research here by these researchers found that their participants, if they did not have an understanding of pain and they worked into pain for their exercise, there were actually less neuroplastic changes on the brain. And that makes complete sense, because from the previous research that we saw, if the participant does not have an understanding of pain, like on the left-hand side here, and they're working into pain, their cerebellum may be doing most of the work for the motor pattern, and their motor cortex is not retraining like we want it to. So if we can give patients a good understanding of pain, we know that that can improve the firing of their pain neuromatrix, hopefully reduce it is the goal, and increase motor cortex excitability. Kinesiophobia will definitely impact how much impact the motor output in the way that it doesn't allow that area of the brain to retrain. So if a patient has a thought that anytime they have pain, they're creating tissue damage or they're making things worse, that thought is going to create fear. And that fear then is going to cause them to move less. It's going to impact their behaviors that way. And if they're moving less, we know that less movement causes an increase in sensitivity of the nervous system. And that increase in sensitivity will probably lead to more pain, meaning that the lack of movement leading to more sensitivity will cause more pain, which will reinforce their thought that they're broken. So our goal is to, on day one, if we can, introduce a new thought that pain is not causing tissue damage. And a lot of times I give people a mantra, either hurt does not equal harm, which we got from Adrian Lowe, sore is safe. It could be that just making sure people know that nudging into pain is safe. And I like to tell patients, nudge into discomfort, don't force through pain. And we'll talk about why in just a little bit. But if I can introduce this new thought of hurt does not equal harm, nudge into discomfort, then when they do that, it's going to be less fear of motion. So less fear of motion is going to cause them to move more and more confidently. And then when they move more, that's going to help decrease the sensitivity of the nervous system. It's going to help retrain their brain. And that's going to lead to less pain, hopefully. And less pain will then reinforce the thought that hurt does not equal harm. So we want to introduce a new thought to get them to understand that nudging into discomfort will actually get them better faster. And this is a picture that I show to just about all my patients on the first day. And this is what I think that we should focus on, especially when the clinic is really busy, it's loud. There's a great way that I explain this to patients that's really simple and it gets the point across. And it's something that we should be able to do with every patient on the first day, if they need it. Some patients don't need this type of education, but for the ones that do, this is what I start with. And I'll explain it to you like I would explain it to a patient. So on the left-hand side, we have a normal response. On the right-hand side is a sensitive response. All of your nerves in your body have a low resting rate, and that means that there's always some electrical activity going through it at all times. As we stimulate that nerve, whether it's pressure, stretch, temperature, blood flow changes, anything that would cause the nerve to change its voltage, it's going to increase and approach this firing threshold. If it ever hits the firing threshold, then it's going to send a signal up to the rest of your body, up to the rest of your nervous system, saying, this is what's happening here. You might want to check it out. And let's say that it's temperature. So if temperature stimulates this nerve up to the firing threshold, it's going to send a signal up to the rest of the body saying, hey, it's kind of cold outside. You might want to put a jacket on. Or if it's pressure, then that when it reaches the firing threshold, it's going to say, hey, there's a lot of pressure here. What's going on? Remember that these signals are just information. It's not telling the brain that there's pain. It's just saying, this is what's happening. What do you think we should do about it? And it's up to the brain to decide what this means. Because we could have things that send signals up to the brain saying, hey, we have some tissue damage here. What do you think about this? And the brain could say, hey, we're just working out right now. We're lifting weights. This is a positive thing for us. We actually want to cause some tissue damage, so this is fine. And you don't have pain from it. When things get sensitive, and there's nothing that makes the nervous system more sensitive than inflammation, that resting rate gets pulled a lot higher. And now it takes much less stimulation to cause the same response. So be aware that the signal on the sensitive side and the signal on the normal side are actually the exact same information. It just happens a lot faster. The important thing here is that this much on the sensitive side to cause a signal is really only this much on the normal side. So normally you wouldn't be feeling anything if the system wasn't sensitive. The only reason that you're feeling pain with this is because the dial got turned up way too high. And there's ways that we can talk about with patients of how we're actually going to get that sensitivity to come back down. But the main thing I want them to understand is that when they work into discomfort, when they have a low level of pain, normally they wouldn't be feeling anything. So if patients understand that, that helps them to understand hurt does not equal harm. I can work into some discomfort. I can nudge into it, and I'm not causing any damage to myself. And they're going to get better a lot faster if we do that, if we have that understanding of pain, because the motor cortex is going to be retraining the right way. So how do we explain pain to patients? I always start with an opening question. My opening question is usually, well, what do you think is causing your pain? Because I've had so many patients where they've been through physical therapy a lot in the past. Nobody's asked them this question, and they come to me. I say, what do you think is causing your pain? And they say things that are just not true. And it takes a lot of some de-education first before we can re-educate. A good example was I had somebody, actually, I'm still treating this person. She came to me after a motor vehicle accident with a pretty significant spinal fusion from T7 to L3. And she had gone through 3 rounds of physical therapy already before coming to me. And I asked her, what do you think is causing your pain in your back? And she said, well, there's screws in my spine. Of course, if I have a screw in my spine, it's always going to hurt. And if that's what she believes, then she's not going to get better. So we had to talk through that and say, my next response was, do you think it's possible for someone to have a spinal fusion with screws in their spine and not have any pain from it? Well, no, of course not, because there's a screw in my back that's going to hurt. So we had to go through a series of, I asked more questions, and eventually we got to the point of her realizing that people have these screws put into their back, their spine will just ossify around it, and people don't notice it. It's one of those things that does not by itself cause her problem. Once she realized that, she's been getting significantly better week by week. So we have to ask the question, or else we'll never know what's going on in our patients' heads. I then need to explain what pain is and what it is not, because like this patient I just talked about, what she thought her pain was actually making her pain a lot worse. And with some patients, you'll find that the way that they think about their problem is actually causing the entire problem. And then we can explain the onset of pain. How did it start? Yellow flags, which are things that happen during the injury or during the acute, subacute phase, which cause the person's brain to think that the injured area is unsafe. Meaning that even after it heals, if all the tissue's healed, it still can be painful because the brain thinks it's unsafe. It links it to this outside stress. A great example of this was I had a patient who had a fracture of her foot, had to have a surgery. She ended up losing her job because of this. And she then unfortunately lost her husband, lost her house, and had to move in with her daughter, and had a terrible relationship with her daughter. That all happened within 3 months. And that's just a terrible situation to be in. And it told her brain that her foot was extremely unsafe. So even after everything healed, she developed CRPS, which is a very difficult thing to treat unless you know a series of steps in how to get these people better. we had to talk through a lot of her yellow flags. Treat people according to their primary category. So there's research by Keith Smart and colleagues looking at how can we separate people, especially complex pain patients, into different categories and know how to treat them differently according to what category they're in, if it's a nociplastic, a peripheral neurogenic, or a nociceptive category. And there's different ways that we can focus on getting each category better. I like to ask, how long do you think these improvements will last? Because I want to get an idea of what the person thinks is going to keep them better. Because we know that doing a lot of our hands-on treatment has a short-term effect. If we want things to have a long-term effect, we want to combine it with our exercise. And if we're going to exercise, we want the person to have a good understanding of their pain and be able to nudge into discomfort for their motor cortex to retrain properly. And then I always like to bring up continued intermittent pain. We know that with most people, especially the more chronicity there's going to be some up and down of pain during their episode of care. And I want people to have a good understanding and be prepared for that, because we want to try to avoid the freakouts over flare-ups. This is not everything that I do in one day. I usually start with the opening question and then get into explaining what pain is, what it is not, usually going through this picture here. And I always have this with me close by when I'm with patients because I reference it a lot. But then, so that's kind of the baseline, and that's a lot of the things that I go over in my course, Understanding Pain. And to look at the next level of explaining pain, especially with any complex pain patient, we want to talk about things like cortical smudging. So these are mapping issues where the brain actually loses the ability to see what's happening in a certain area. And that's very threatening for the brain. That makes the pain neuromatrix very active. And so how do we redefine an area on the cortex? Laterality issues, sometimes patients with complex pain can lose the understanding of left versus right. So how do we test for that? And then how do we fix it? Just talking through central sensitivity in general, how can we explain that to patients? Being able to test for and treat premotor pain. So this is when just thinking about emotion can cause pain. With my patient who had the foot surgery and a lot of complex regional pain syndrome after that, just thinking about tapping her foot without actually moving at all could shoot her pain up to a 7 out of 10. So how do you fix that? Talking through ion channel expression. Ion channels on our nerves will change based on what our brain thinks we need. So how do we treat a person when we know that, or we suspect that their brain has changed the ion channel distribution to maybe be very sensitive to stress or be sensitive to stretch or pressure? How do we fix that? Carbon dioxide intolerance. When people are under chronic stress, especially 2 weeks or more, then the body can actually shift to be less tolerant to carbon dioxide, and that can cause a lot of issues as well with hypersensitivity and anxiety. So how do we treat breathing dysfunctions like that? Motor drive problems. What happens when, I'm sure everybody's had this patient where they come in, their abduction looks like this, lots of compensation, you do a lot of work with them, hands-on and exercise, and you eventually get them to reaching into abduction with a good pattern, and then they come back the very next visit doing the exact same thing as they did before. They're doing their home exercise program and they tell you, I go to bed, I wake up and it's back to this and I can't keep it better. That's a motor drive problem. And how do we fix that? Micronutrient deficiencies. We don't really think about this as much because it's a little bit out of our scope, but we still can have access to patients' charts and see where, if they've had recent labs, we can see what their micronutrient levels look like. Things like magnesium being deficient, that can cause some issues. If it's on the motor side, it can cause spasming. If it's on the sensory side, it can just make the patient hypersensitive to different stimuli. Or things like copper. If somebody's deficient in copper, that can cause radiculopathy, radicular pain type symptoms, usually starting in the upper extremities and working towards the lower extremities. And if they're having this and we're just treating them like a normal cervical radicular patient, then we're never going to get them better. We need to keep our eye open for these type of things. And then how do we explain complex conditions like fibromyalgia, chronic fatigue syndrome, or long COVID? I've had a couple of patients with long COVID pain that we had to do a lot of the things on this list to be able to get them better. And there's more than this, but I really think that eventually I'm going to have a class for just complex pain, going through all these different situations. The best thing we can do is just start with this. Most of the patients that we see just need to have a basic understanding of what their pain is and why they're having it, and that nudging into discomfort is not going to make their problem worse. If they force through the pain, that could definitely make their brain protect the area more, but just by nudging into it, that actually can make them better faster. Okay. So please check out glseminars.com and look for my class, Understanding Pain, and also look for other classes near you. And I really appreciate the question, and I hope to see a lot of you soon. Take care.